Hello everyone, I hope everyone can hear me now. So first of all, I would like to thank everyone for attending to this webinar. Let me introduce myself. My name is Balint Lakatos. I'm a medical advisor of Argus Cognitive, and I was fortunate enough to be involved in the development of our unique right ventricular assessment method, the revision method. And I'm also a practicing clinician. I'm a cardiologist of Semmelweis University Heart and Vascular Center in Budapest. Today I would like to talk about you the echocardiographic metrics of the right ventricle, mainly focused in pediatric cardiology and also, of course, in congenital cardiology, and with a special considerations regarding the added value of three-dimensional imaging, and about our method for the in-depth assessment of the right ventricle function. As a short disclaimer, I'm actually an adult cardiologist. However, I had and have some experience with children and with pediatric cardiology as well. If you have any questions, I'm more than happy to answer them after the webinar, after the presentation. So feel free to ask, and I'll do my best to answer those questions. So, why the right ventricle? Let's start with that. So it's generally less studied than its left counterpart, probably due to its complex geometry and its function. The left ventricle has a kind of a simple shape, like a shape of a bullet. However, the right ventricle is much more complex. So regarding its geometry, from a long axis, it has a triangular shape. From short axis, it has like a crescent shape wrapping around the left ventricle. And also its function is quite unique, quite different compared to its left counterparts. Importantly, numerous therapeutic options or approaches are known for the left ventricle. The last few decades was a absolute huge success regarding this. We have a lot of pharmacological options. We have a lot of non-pharmacological options to treat left ventricular dysfunction, left ventricle failure. We do have some for the right ventricle as well. However, considerably less, and probably that's why we are seeing increasing number of right heart failures, primarily right ventricular dysfunctions in our patient population. Right ventricle is especially important in congenital heart diseases, and of course it has an utmost importance regarding the right side of the heart, especially when the other side is hypoplastic or almost absent, because we do know that there are some patients who has actually this condition. Approximately 20% of congenital heart disease patients develop heart failure. That's a very huge number, considering that a large proportion of congenital patients have actually a milder condition, and 77% has clinical and or echocardiographic signs of right ventricular dysfunction. Therefore, it nicely shows us that's quite an important topic to discuss and to investigate. So, yeah, a high proportion of congenital heart disease patients have primary right heart abnormality or have biventricular abnormality. And congenital heart disease patients have an extremely high risk of developing heart failure, more than 100-fold, with much more limited therapeutic options compared to left heart disease, adult heart disease patients. And as I've already mentioned, a very huge proportion of them have primary right ventricular dysfunction. So, what do we know about the echocardiographic assessment of the right ventricle? Echocardiography is the mainstay method for the assessment of the right ventricle, of course, and in parallel with its advancements in echocardiography, more and more sophisticated parameters were introduced. And we know that it's a very fast, relatively fast, I would say, non-invasive, quite cost-effective method which allows a comprehensive imaging of the cardiac functions and the blood flow. However, regarding the right ventricle, we have a bit more limited options, and we will see that the vast majority of parameters that we use actually assessing the longitudinal shortening of the chamber, and we do know that the right ventricle actually has a much more complex contraction pattern with contraction along non-longitudinal axis as well, and it can be easily demonstrated on these two patients on the left lower bottom of the image. So here we see two patients. On the left side we have a young elite athlete patient. Actually he's doing kayaking 20 hours a week with a very pronounced longitudinal shortening. On the right side we see a patient approximately the same age. However, he just underwent a heart transplantation. This acquisition is just a few days following his operation. And even just by looking at these two images, we can easily appreciate that the global function maybe looks roughly the same. However, the contraction pattern of these patients are markedly different. Still, the majority of parameters that we use doesn't really precisely tells us about these marked differences. That's why the detailed assessment of the myocardial mechanics may have a real added value, and it worked very nicely in terms of the left ventricle. And if we examine the Myofiber architecture of the left ventricle, it's easy to appreciate why. So this novel approach, the assessment of myocardial strain, the assessment of the different myocardial contraction, deformation directions, really revolutionized echocardiography because the different layers of the myocardium generates different motion directions. So if you're looking at the left ventricle, we can see that the subendocardial layer has a mainly longitudinal orientation, mildly oblique, which generates a mostly longitudinal motion, and that's how we can quantify the motion of this layer by examining the longitudinal strain, the longitudinal deformation. The middle layer of the left ventricle consists of mainly circumferential fibers. So the assessment of the circumferential shortening, the circumferential deformation, may brings us closer to the function of that layer. And we also have a subepicardial layer, which is a longitudinal, also longitudinal and also mildly oblique architecture. And the different motion directions and the assessment of different deformation directions can give us further information about the actual mechanics of the chamber. We can also implement this method for the assessment of the right ventricle. However, the right ventricle has a markedly different contraction pattern, markedly different Myofiber architecture actually. So the right ventricle has a inner subendocardial Myofiber layer, which consists of mainly longitudinally oriented fibers, but it also has a subepicardial outer layer, consists of circumferential fibers. So, as I've already mentioned, the majority of right ventricle parameters only assesses the longitudinal direction. However, we still have this other circumferential layer, which also generates a considerable amount of ejection. Moreover, we all know that near the right ventricle we have its left counterpart, the left ventricle, with almost 5 times more myocardium compared to its right counterpart, actually only in healthy conditions, of course. But the left ventricle also markedly, importantly contributes to the right ventricle function. and maybe it can be also assessed. We'll talk about it later. So there are three major mechanical components of the right ventricular pump function. First, we have the longitudinal motion, so the shortening within the longitudinal axis, and it generates a traction of the tricuspid annulus towards the apex. On the right side, we can easily appreciate it on this apical four-chamber image. But we also have the inward movement of the right ventricle free wall, so this bellows-like action of the right ventricle, making a radial, making a transversal contraction of the chamber. Moreover, there's a anteroposterior motion as well, so a shortening along the anteroposterior axis due to the contraction of the left ventricle. So the right ventricular insertion points are pulled towards each other by the left ventricular contraction, and it also actively contributes to the global function of the right ventricle. So what kind of parameters do we use in the everyday clinical practice? First, let's take a look at the one-dimensional, so linear functional parameters. Probably for the assessment of the right ventricular function and longitudinal function, TAPSE, so tricuspid annular plane systolic excursion, is the most commonly used measure. So it uses a M-mode imaging, and it quantifies the absolute displacement of the tricuspid annulus during systole, and therefore it's a quite easy to measure and quite simple parameter that we can use in the everyday practice, which is a definite advantage of this parameter. We can also definitely say that decreased values correlating quite well with morbidity and mortality. So it can be almost perceived as a semi-quantitative measure when in which the decreased values usually mean deteriorated global function and consequently associated with poor outcome. However, the maintained values not necessarily mean maintained global function, and we cannot clearly determine mildly, moderately, or severely depressed values of it. And as I've already mentioned, it refers solely to the longitudinal shortening. And we all know that it's also very highly influenced by the loading conditions, so by the preload and afterload of the chamber. And it's also quite commonly seen that the postoperative value, so after a cardiac surgery, the postoperative value of TAPSE is usually decreased, and it's not accompanied by right ventricular failure, signs of right ventricular dysfunction, probably due to the changes of the right ventricular mechanics. Therefore, TAPSE is quite simple to use. However, it not uncommonly fails to really deeply assess right ventricular function for us. We have normal values in infants, children, and adolescent patients. In the pediatric population, it's a bit more tricky to assess the right ventricular function and cardiac function in general, because the body size, because the age very substantially affects the normal value. However, we have nice reference values for TAPSE in a large population of healthy pediatric patients, and not surprisingly, it shows a very clear association with the age and with the body surface area of the patient. At the first months of life, its value increases quite significantly, probably with the gaining of body size as well. And as you can see, its normal value increases throughout childhood. However, as I mentioned, TAPSE fails to correctly quantify right ventricular function in a quite considerable amount of cases. We have 2 patients here, and their TAPSE value is actually almost the same. However, if we just take a glance of these patients, we can easily appreciate that something wrong is going on. So what do we see here on the left side? That's a patient with a definitely severe right ventricular failure with a severely depressed right ventricular ejection fraction. However, on the right side we have this patient with almost the same TAPSE value, however doing completely well and has no symptoms. Actually, there's the same patient that I showed you a few slides ago. He underwent a heart transplantation, and this is his echo just a few weeks after the transplantation, completely different. Still, we have a completely different right ventricular function just by taking a glance of it. So we have another approach for the assessment of longitudinal function in children, which is the measurement of right ventricular outflow tract systolic excursion. The rationale of it is actually similar to TAPSE, so we can measure the excursion of the right ventricular outflow tract with an M-mode image. However, it assesses a completely different region. So compared to TAPSE, it's not examining the movement of the inflow, but the outflow tract of the right ventricle. Importantly, it's also feasible from a parasternal view. Of course, in very young patients, of course, in patients with a much smaller body size, sometimes only the parasternal or apical views are feasible, and in those patients we can also measure this parameter, which may be useful sometimes. We have also reference values for that, and not surprisingly, it shows us a quite similar changes to TAPSE. So in the very few weeks and months of life, it increases markedly, and it shows an increase throughout the whole, throughout the entire childhood. Yeah, we were talking about the longitudinal motion. However, there's also non-longitudinal motion of the right ventricle, and it was already examined by simple methods in the past. So there is this early report using simple one-dimensional measures. Hashimoto and colleagues measured TAPSE and also measured right ventricular free wall inward motion in a large subset of children in different age groups, and they actually reported similar changes regarding TAPSE to the previous data, to the data of Kostenberger and colleagues. And they also measured the right ventricular inward motion, so a more or less measure of this radial, this bellows-like motion of the right ventricle. And interestingly, they showed us a reciprocal change of this inward motion to TAPSE. So the ratio of right ventricular inward motion and TAPSE decreased along age, with the largest decrease in infants in the first few months of life. So it suggests us that there's a very drastic change in the mechanical pattern in children at the first months of life, which goes on actually throughout childhood. However, we only have this let's say more simpler one-dimensional data about that. But nowadays we have much more complex, much more precise methods for that, and we'll get back to that topic as well. So in overall, non-longitudinal motion components are definitely quite interesting in children as well. We can also assess fractional area change, which is done by contouring the right ventricular endocardial border in diastole and in end systole. And the difference of them is divided by the end diastolic area, and therefore we can quantify the right ventricular motion with the right ventricular systolic function with these methods. There's a very important advantage of it, which is that it incorporates radial motion as well. We do know that it correlates nicely with MRI data, better actually than TAPSE. And for the postoperative assessment, it may be a more adequate method because, as already mentioned, following cardiac surgery, TAPSE quite commonly fails to adequately characterize the overall global right ventricular function. However, it's very hard to find a standard view for fractional area change. We are advised by the guidelines to use a standard view, a right ventricle focused apical view, in order to measure it. However, only very, very small adjustments of that view can result in substantial changes in fractional area change measurement. We also have to emphasize that it only quantifies the right ventricular inflow, so the function of the outflow tract is not represented by the fractional area change value. We have definitely issues with endocardial delineation because especially in congenital heart disease patients, we do know that the trabeculation of the right ventricle becomes much more pronounced, which sometimes makes harder for precise delineation of the actual endocardium with echo. And previous data shows that it has a definitely poorer reproducibility compared to TAPSE. We can also use tissue Doppler based methods, for example, the pulsed wave tissue Doppler imaging of the tricuspid annulus. It's also a mostly easy to obtain parameter, so in the vast majority of patients it's feasible and can be done. We can also assess both systolic and diastolic parameters, so we can assess not just the contraction but the relaxation abnormalities of the right ventricle. And by using a TAI index, so measurement of the isovolumetric contraction and relaxation time, and dividing it with the ejection time, we can yield a more integrative marker of the right ventricular function. However, similarly to TAPSE, actually it only refers to the longitudinal shortening only, and it has a very significant angle dependence, as all Doppler measures do have. And similarly also to TAPSE, again similar to TAPSE, the postoperative values of that measure are, let's say, consistently decreased and do not represent the actual contractile state of the right ventricle, which is once again a very important limitation of that method. We also have reference values for the peak systolic velocity of the tricuspid annulus with tissue Doppler by Kostenberger and colleagues, and also z-score numbers actually. Interestingly, compared to TAPSE, there's a different change throughout aging. As you can see, actually for a 6-year-old, the tissue Doppler S-wave, so systolic wave value of the value in a children with 6 years of age is actually more or less the same as an adult. So it reaches this around 12 centimeters per second in velocity. So in terms of this parameter, we have to assess this a little bit more differently. Okay, so one of the most important advancements of echocardiography imaging was definitely speckle tracking echocardiography and strain imaging from the last decade. We can nowadays we have dedicated right ventricular softwares for the deformation imaging of the right ventricle, and this approach, so measurement of right ventricular strain, is definitely a quite useful and interesting approach for the assessment of systolic function. Right ventricular longitudinal strain, the measurement of it is nice and nicely reproducible. Softwares nowadays are quite well comparable actually. It has a very good sensitivity. Importantly, it doesn't just give us global information, but also segmental information of the ventricle. And it has a quite strong prognostic and diagnostic value in patients in a large number of conditions. Here only myocardial infarction and arrhythmogenic right ventricular dysplasia is highlighted, but there's many more populations in which it was proven to be a strong predictor of outcome. However, the specificity of it is definitely poorer than its sensitivity. We also have problems with getting a standard view. The acquisition of a standardized right ventricle focused apical view is definitely hard. There again, we have a parameter which refers only to the longitudinal shortening of the chamber, and it has a quite significant preload, and let's emphasize that also actually afterload sensitivity of right ventricular longitudinal strain. We also have normal ranges for children regarding the systolic and diastolic strain measures. In generally, we can say that in children we can expect higher normal values compared to adult individuals. The mean value of right ventricular longitudinal strain was 29%, and in this large population, the lower normal value was found to be 24%. So compared to the generally accepted 20% of strain in adults, in children we want to look for a we want to look for a mildly higher normal value of 24%. 3D imaging. 3D imaging allows us a more complex assessment of the right ventricle. By the measurement of right ventricular volumes without the use of any geometric formulas or geometric assumptions, we can precisely calculate the ventricular volumes, and therefore we can measure right ventricular ejection fraction. So we have real volumetric measurements, which is a huge pro for three-dimensional imaging, especially for the right ventricle, because the complex geometry of that chamber does not allow us to use such easy formulas like the Simpson method for the left ventricle. However, we have some disadvantages. First of all, I would like to highlight echo window, which is not a problem in approximately 80 to 90% of patients. However, we are talking about adults. Multi-beat reconstruction is often not possible in cases of arrhythmia, in cases of distinct conditions when we cannot ask the patients to hold their breath. In case of children, that's quite often the case. And also there's a general underestimation of the values compared to CMR. However, in overall, we can see that the volumetric assessment is markedly better compared to other methods. Let's just talk shortly about feasibility, because in children and in assessment of echocardiography measures in children in general, it's a bit more complicated. And if you look at these two X-ray images, we can easily see why. So here we have much smaller intercostal spaces to assess the heart, to assess the right ventricle. In children, it's quite common that the right side of the heart is much more situated behind the sternum, which limits the visibility of it. However, let me show you an example of a 5-year-old children. This acquisition was done by me. Here we can see that actually the three-dimensional imaging in the children is definitely not impossible, and not just a toy for the scientific purposes. We can do that. There will be some cases in which it's not possible, but by giving some more time to it, it usually works. Why do we want to measure three-dimensional measures? Why? So actually, for the definite added prognostic value of right ventricular ejection fraction, we have substantially more adult data. So I will present this for you, but we'll get to some congenital cases too. So we do know that in patients who are free of heart failure, lower right ventricular ejection fraction was associated with incident heart failure and death independent of the measurement of left ventricular ejection fraction. And the impairment of right ventricular ejection fraction carried a significantly higher risk of mortality in another study, independent of left ventricular ejection fraction. In a recent meta-analysis of ours, we have showed that compared to the more conventional measures and even measures of right ventricular function and even right ventricular free wall strain, three-dimensional ejection fraction had a superior ability to predict outcome in adult populations in a meta-analysis of adult studies. Moreover, three-dimensional imaging gives us the opportunity to perform a detailed characterization of the right ventricle mechanics. We have some preliminary data which reflect that approach is absolutely feasible. In an early cardiac magnetic resonance study, the right ventricular ejection fraction was better reflected by the transverse motion rather than the longitudinal motion in pulmonary hypertension. So let's get back to the major limitations of assessing longitudinal function. Sometimes they do not show that nice correlation with the global function. And in another study, the assessment of regional deformation was a better marker of survival than the global measure. So probably there's an added value of the decomposed and also the segmental analysis of the right ventricle. However, we didn't really have a established method for that, and that was that problem that we faced with, and that initiated in us the need for the development of such method. There are some more preliminary data. For example, there's a study with pediatric pulmonary hypertension patients, and in these patients, the global and also the regional deformation was markedly different compared to the controls. And the idiopathic pulmonary hypertension patients and the congenital heart disease pulmonary hypertension patients significantly different actually regarding their global and also their regional strain pattern. So it's also highlights for us that these measurements may have an added value, and actually in this study there was some prognostic data as well showing us that these regional measures actually were predictors of adverse event, while the conventional measures was not. Another interesting way to characterize right ventricular contraction and right ventricular function in general is the analysis of right ventricular shape. So, for example, we have a example generated by us, a normal individual and a patient with pulmonary hypertension. We can easily appreciate that the regional shape of that right ventricle marked by the coloring of convexity and concavity in these patients are definitely different. So actually there's some data about that as well, in which the curvature analysis, so the assessment of concavity and convexity of the right ventricle had a interesting quantitative evaluation of the right ventricular remodeling, and also was a nice marker for the progression or the regression of the disease in this small cohort. So, what about our approach? As we already showed you, the contraction pattern of the right ventricle is quite colorful, quite different in different scenarios. So our method, the revision method, right ventricular separate wall motion quantification, decomposes the global contraction pattern of the right ventricle. So on the left side of the image of the slide, you can see a right ventricle mesh throughout systole and diastole with its global untouched mechanics. So revision method will decompose this three-dimensional motion of the right ventricle. Therefore, we can assess the longitudinal, the radial, and the anterior posterior motion of the right ventricle separately. So by basically switching on and off the motion components, we can separately quantify the absolute and the relative contribution of them. What are we doing? So first we can perform a motion decomposition, as I've already showed to you, and we can quantify theoretical meshes in which only the longitudinal, only the radial, or only the anterior-posterior motion of the right ventricle is only enabled. Therefore, we can quantify the relative contribution of them. Moreover, we can also do segmentation of the right ventricular function. So not just global, however, regional measures can be quantified as well. And we also have the ability to measure circumferential and longitudinal three-dimensional strain of the right ventricle, not just globally once again, but segmentally as well. The workflow of revision is quite simple. So first we do a three-dimensional image acquisition, and after that we are reconstructing the three-dimensional right ventricular models. Initially we were using the TomTex software. After the analysis using the three-dimensional right ventricular assessment software TomTex, we can easily export the three-dimensional right ventricular model. However, we have to emphasize that we can also do it using raw dicoms as well nowadays. First, we are doing a pre-processing by standard reorientation of the right ventricular mesh, and after that the software does the segmentation to our custom 15-segment model. And after that we calculate our right ventricular metrics. So first we are doing the decomposition, but we are also doing a strain analysis in order to quantify longitudinal and circumferential strain measures as well. An ever-coming question is the validation of this method. Fortunately, we had the opportunity to validate revision against, let's say, gold standard cardiac magnetic resonance imaging, in which we were able to demonstrate that there's a very, very close correlation of the measurement of the values of our decomposed metrics, either by measuring it with echocardiography or cardiac magnetic resonance imaging. What can we quantify? What can we assess by using revision? So there are multiple. There's a handful of scenarios in which the contraction pattern shifts within the right ventricle. One of them is the changes in myofiber architecture, which occurs actually in a lot of clinical scenarios, and congenital heart disease is definitely one of the most important of them. We have this interesting study here about the muscle fiber orientation in patients with tetralogy of Fallot. What we can see here is that compared to healthy individuals, patients with Fallot tetralogy have that middle circumferential myocardium layer that is usually characterizes only the left ventricle. However, in this congenital heart disease, this circumferential myofiber layer is present also in the right ventricle, and it will have a definite importance that we will see later. Also, there are some acquired causes actually of the changes in myofiber architecture. In the pressure overload model of pigs showed us in a previous study that actually the muscle fiber orientation changes with the pathology, and probably it will lead to changes of the right ventricle mechanics as well. The contraction pattern also shifts by the opening of the pericardial sac. We see this in the everyday practice. Those patients who undergo cardiac surgery have a markedly different contraction pattern. And there's a very important or very interesting patient subpopulations who underwent cardiac surgery, a special type of cardiac surgery, more specifically heart transplantation, in which the denervation of the donor heart may also be an important of cause of that contraction pattern change. So there's a lot of clinical scenarios which sometimes occur simultaneously, which can change the contraction pattern. There's that very simple example. We have a patient prior and after a mitral valve replacement. We see that the TAPSI value is absolutely maintained before the surgery. However, following the valve replacement, the TAPSI value becomes markedly decreased. However, it's not accompanied by signs of manifest right ventricular failure. What we can also see here is that maybe the bellows motion of the right ventricle also became more prominent. So there's definitely things that we can assess here. What about the relative importance of these mechanical components in healthy pediatric individuals? We have a collaboration with Boston Children's Hospital, with Harvard, in which we enrolled 166 patients, 166 healthy children of various age groups. What we have seen here is that the anterior-posterior motion is actually greater than the radial and the longitudinal, also when adjusted to the right ventricular ejection fraction. So the absolute values and the relative contribution of these anterior-posterior motion components is higher in children compared to the other two motion components. And actually, right ventricular ejection fraction and also the radial and the anterior-posterior motion components decreases with aging, and the longitudinal motion, the absolute and the relative contribution of that longitudinal motion will be more or less the same. Our study is now actually under review. Hopefully we can publish it soon, and it will be freely available for everyone. Recently we published an interesting study in which we enrolled pediatric kidney transplant recipients without overt signs of any kind of cardiac disease. So this is a non-cardiac disease population. However, we can definitely say that they are a high-risk population with multiple risk factors of some kind of cardiac dysfunction. What we have seen here is that patients had a mildly depressed right ventricular ejection fraction compared to healthy controls, which was mostly attributable to the decrease in right ventricular three-dimensional longitudinal strain, which was significantly lower in the pediatric kidney transplant population. However, the right ventricular circumferential strain was comparable between these two groups. So even though there was no overt cardiac, it's not an overt cardiac disease population patients, we are able to demonstrate some mild but definitely seeable changes in the right ventricular motion in the contraction pattern. And actually, this right ventricular, this decrease in the right ventricular deformation was also showing a correlation with the length of dialysis time or period of the transplanted populations. So it more or less reflects the previous cardiac damage of the underlying disease. What about congenital heart disease patients? So we had a previous study, a previous collaboration with Padua, Italy, in which we were examining patients with repaired tetralogy of Fallot who had severe pulmonary regurgitation. As we all know, it's not uncommon in patients after the repair of the underlying congenital disease. What we have found here is that the global ejection fraction of these patients were also impaired. However, the motion pattern was showing an even more pronounced, had even more distinguished characteristics. So the longitudinal motion of the right ventricle was markedly decreased in the Fallot tetralogy of Fallot population compared to the healthy volunteers, while the circumferential motion was comparable or even higher compared to the healthy individuals. So let's just reflect to our previous slide about the changing in Myofiber architecture. This middle circumferential layer in Fallot tetralogy patients can be seen actually in the global function as well. So They have a decreased longitudinal function, however, they have a more pronounced circumferential shortening, a more pronounced radial function, which can be easily characterized using the revision method. One of the, let's say, pinnacles of congenital heart disease is maybe the patients with systemic right ventricle. So transposition of the great arteries and congenitally corrected transposition of the great arteries patient. So in a collaboration with Royal Brompton, we have examined this patient population. We had patients who underwent mustard or Senning, so atrial switch surgery, and patients with congenitally corrected transposition of the great arteries. What we have found here is, interestingly, while the global function was definitely, the ejection fraction was definitely decreased compared to the healthy control population, the anteroposterior motion of the right ventricle was relatively preserved in our population. Moreover, the relative contribution of the anteroposterior motion was even higher compared to the controls, which maybe tells us that that this anteroposterior motion component, this interaction with the left ventricle, has a very big importance in this very distinct population of patients with systemic right ventricle. Still, we have to admit that ejection fraction and also strain measures are heavily affected by other factors. Which are these factors? Namely, the loading conditions, so preload, and maybe more importantly, afterload heavily influences our functional measures. The synchrony of the chamber, which is quite commonly neglected but very heavily influences the global function. And also the chamber geometry is a very important determinant of the global function. How can we tackle this load dependency? So, ejection fraction and strain measures, as mentioned, are rather markers, actually, not the contractility, but based on our previous studies, more like ventricular arterial coupling. As an academic researcher, we investigated the load dependency of conventional measures of strain and ejection fraction, and they were not associated actually with contractility. So with the intrinsic load-independent ability of the myocardium to shorten. Myocardial work index is an interesting new concept. So adjusting myocardial deformation to the corresponding afterload maybe mitigates the afterload dependency of strain, and the strain loop groups may have a real added value in patients in which the loading conditions are markedly altered. We have some preliminary data regarding the left ventricle. We had previous studies in which these myocardial work measures showed nice correlation, markedly better correlation with contractility. And we even think forward, so we would like to add volume into the equation, and by generating three-dimensional loops, right ventricular pressure, strain, volume loops, we want to measure systolic function independently of afterload and preload, so actually measure contractility in a real non-invasive way. It's coming soon, so what are we doing here? We have estimated right ventricular pressure curves. We'll like to use a non-invasive method, so measuring or estimating the pressure curves using only the tricuspid regurgitation peak velocity. We have longitudinal strain curves by our method. Therefore, we can calculate pressure strain loops, and by even thinking forward, we can add the changes of right ventricular volume to this pressure strain loop. So adding the instantaneous volume change frame by frame, and therefore we can generate three-dimensional pressure strain volume loops. This method is under construction currently. However, we are on the way, and we have the preliminary data, and I'm very hopeful that we can present you the first results quite soon. We have one example here that you can see, a patient with a normal right ventricular ejection fraction and with no apparent abnormality actually, and the combined volume and pressure overload patient. What you can see here is that the right ventricular ejection fraction of these two patients are absolutely the same. However, if you just look at these two loops, you can instantly see that there's some very marked difference between these two patients, and this method may be able to nicely to adequately characterize it. As a future perspective, so our research group, our group, Argus Cognitive, overall is heavily involved in the development of AI-based clinical decision support systems, and we believe that that in dedicated populations, the integrative assessment of basic clinical data and the in-depth analysis of the right ventricle mechanics, the right ventricle function using revision, may open the gate for even more tailored diagnostic approaches and also clinical decision making in general. So there's still a huge gap to fill in overall, because according to a recent worldwide study, only 50% of the echocardiographic machines are able or capable for three-dimensional imaging. However, I have to emphasize that the other 50% of it is nowadays, so a considerable proportion. However, even in 2022, 44% of clinicians report only qualitative and no quantitative information about the right ventricle, and only a small proportion, only 17% of clinicians use three-dimensional echocardiography in their clinical practice to assess the right ventricle. So there's still a huge road to walk. And there's 30% of clinicians who never used three-dimensional imaging actually. But a simple and automated solution that may provide a more powerful measures of the right ventricle therefore is a very, very pressing clinical need. So our method is revision method is available online as a online application. Its demo is available on that link that you can see here below. And if you want to, if you would like to see a demo, a personal introduction to our method, we are more than happy to help you in that. So please feel free to contact us, and we can actually arrange it. We can show you the capabilities of revisions. As a conclusion, there's a growing attention to the clinical importance of the right ventricle, irrespective of which side of the heart is affected. There's a growing number of promising novel functional parameters which eliminate the limitations of the conventional ones, and there are growing possibilities for advanced automated analysis and decision making. I would like to thank you for your kind attention. There's my email and also my LinkedIn account. I'm here for answering your questions. If you have some questions that you'd like to ask in an email, I'm more than happy to receive those. So I'd like to thank you for your kind attention. Let me see if there's any questions. Actually, I don't see any. So if you'd like to, then feel free to contact me in my email address. Feel free to contact Argus Cognitive, and I would like to wish you a nice afternoon or morning, depending on where are you attending from. Goodbye. Thank you for listening. Oh, I see a question. Let me answer it for you. So radial, longitudinal, and anteroposterior ejection fraction does not add up to right ventricular ejection fraction. Yes, that's a common question. So what we have here is that the radial, the longitudinal, and the anteroposterior motion components are actually not additive. However, they are multiplicative measures. So that's why they do not add up for mathematical reasons. For the current version of the revision method, we actually can report such longitudinal, radial, and the anteroposterior ejection fractions, which are additive. That was only by restructuring the equation which generates these values. So yeah, in a sense, it's not a problem, not a limitation, because they are not additive but multiplicative values. But we do know that it may be disturbing for some individuals. So actually, we have a solution for that. So we can calculate it in an additive manner as well. Any more questions? If not, I would like to thank you for your attention once again.